I just turned on the recording, as you can hear. Who else joined? So I was hoping you were going to the health conference this year. I'm sad you're not going, Dawn.
I'm sad too. This is the first time in many years.
Yikes. Are you signed on twice, once with your phone and once with a computer?
I am, but I thought I had everything muted. I'll take a look.
Okay. Good morning. Cynthia, are you on? Good morning. Hello, who just joined?
Hi, Patty. This is Tammy.
Hi, Tammy.
How are you?
I am excellent. And so we've also got Dawn on, that's Tammy Anderson from CAMC, and Dawn Artur on from Lowell. It looks like Cynthia Devroye has joined, but I see she disappeared. Oh, there you are.
I'm here. I was just about to say good morning.
Good morning. Okay, so I'm not sure how long we should wait because I'm not positive if I don't think Marcia's going to make the call from Covenant, and I'm not sure if anyone's joining from Concord or not. So I've started a recording, and maybe we'll just give it a couple more minutes, and then we'll kick this off. What I've done for those of you who are using Teams already is I've set up a team site for this group. And so you should have received an invite to it, and it's just called Access Roundtable. In it, we've got a general area, and under the general area, we have a single file out there so far, and it's the site description file. So it talks about what each of you are live with, and that's just so, if you wanted to speak to somebody who's using something you're not and get information, that there'd be a place to know what the people in this group are live with. I've set up channels, one for acute registration, one for acute scheduling, one for CPM, one for eligibility, and we can set up as many channels as you want. And those are just for if you wanted to post questions or get any information from the group, that would be where you go. Who just joined?
Hi, this is Christian LaValle from Concord Hospital.
Hi, Christian. Awesome. We were just getting going now, and do you know if Thomas is joining as well or not?
He was going to try to, but I think he had a conflict, so it was, let's see.
Okay.
Let's see if I can I'll try to ping him to see. Doesn't look like he's available right now, though, so he might not be joining.
Okay, and I'll just continue with what I was saying. What we've done is we've started a couple of these groups with our clients, and we're calling them roundtables. And what it is just an opportunity to share what you're doing at your site and hopefully learn from other sites. So we have a group going for CMIOs. We have a group going for PMOs. This is our third group, the access management one. If you guys all feel there's value, we will probably also start a patient accounting one, as well as I know Brian's working on setting up a chief nursing officer one. But again, it's just so that you have the ability to share information between the sites and hopefully have others learn from mistakes you've made or from successes that you've had. so that we get better use out of the Cerner systems that you're all using. So what I had intended for today is a really tall order, and so there's no way, I know we're not going to get through this agenda, but we'll just carry topics over to the next one that we don't finish. So the first part was to do site introductions, and I sent out a site survey, and some of you completed that survey, and the idea would be to drive through that information, and the ones who haven't completed it, I'll enter it as we go, so that at the end you'll all have a place to go back to see, like I said, what the other sites are live with and who you could reach out to if you wanted help with something. The next agenda item was going to be premium eligibility, then inpatient notification process, medical necessity process, including modifiers, and the patient status order process. So there's no way we're going to get through all of that in an hour, and I realize that. I just put out the agenda so that you would see the sorts of topics that we were anticipating covering. And one of the things that that Covenant indicated was they're not using Cerner registration yet, and so they wanted to make sure that there was going to be value in it for them as well. And they are using CPM for ambulatory. So I did say that, like, this one was much more inpatient focused, but I'm looking for all of you to provide the agenda topics so that going forward it might be a little bit more balanced in the topics that we cover. Okay, so if I switch here over to the spreadsheet that I set up based on the survey information, what I thought I would do is just go alphabetically by site and have you introduce yourself and then walk through sort of what's in this slide, talking about how many facilities you have, the clinics you have, what you're currently using in Millennium, any bolt-ons you have, your go live date, all that sort of information. And truly it's just so that we can fill this out and it'll remain on this site so you'll all have access to it, so that if you're looking for somebody similar, that you could go out here and find it. As well, I'll say up front that if any of you have any other sites that you're working with that you think could benefit from participating in this group, just send me the information for whoever your site contact is, and I'll reach out to them. So I'm going to go alphabetically and turn it over to Tammy Anderson, who is the Patient Access Director for CAMC, and she can introduce her site.
Hi there, how are you all?
I'm
Good,
well.
thanks.
Good. So as Patty said, I'm with Charleston Area Medical Center in Charleston, West Virginia. We are a 4-hospital health system. We see roughly 650 to 700,000 patients a year, around 956 licensed bed. In addition, we have about 50 ambulatory clinic locations. We are provider-based, and everything is billed using one tax ID number. A list of bold ones that we currently have, mostly from the access perspective, is Experian. We have premium eligibility, notice of admission, MedNec authorization, and we're in the process of implementing Patient Safe and Patient Simple.
So you're also, are you not using the appointment reminders anymore?
Oh, yeah, we use the appointment reminders from the scheduling perspective. We have some additional bolt-ons on the patient accounting side, but I didn't list all those out.
Okay. So
tap it on the access side.
So the other thing that I would note there is CAMC isn't using CPM live yet because of the fact that they went live in 2016, and so it wasn't working well enough to go live at that point, and so they're still using Win32 for both inpatient and ambulatory scheduling. So, you know, Tammy may be looking to some of you in the future for your experiences with the CPM functionality and when she might want to make that switch from Win32 to CPM.
Thank you, Patty.
Well, I mean, that's the reason for this. So I know, like I said, Covenant expressed concern about joining because they weren't live with Reg and Sched yet. And honestly, when you look across all the sites, everybody's live with a different mix. So I think that's one of the good things about this group is the ability to share. So again, your go live date was September the 14th, 2016, and that was for both Reg and Sched, and that included your ambulatory as well. And then,
Yes, we did the Big Bang, just to share additionally. I mean, we went live with financial, acute, clinical, the whole bang, one time.
and are you guys on the 2018 code yet?
Yes.
Okay, so I'll just add that then. And so then if I can turn it over to Christian then to give the introduction for Concord, that would be great.
All righty, we're at 295 bed hospital. Went live in December of 2017. Big Bang. 295 beds, 20,000 or so admissions a year. We basically bought the whole catalog. We have one main hospital facility, number of ambulatory clinics, I want to say around 40-ish, when you include rehab and our diagnostic centers. Majority of we think of it as our acute registrations live in PM office and chat book, diagnostic scheduling. All of our clinics use CPM.
Yeah.
We've thrown in.
So is what I listed here correct then? I did this based on what I thought
Yep.
Brian was. Okay.
Yep, perfect. Brian did a good job. Current bolt-on. We use appointment reminders through Cerner, Rapid Call. We just use regular eligibility at this point. We did not turn on Experian eligibility. We really don't have a problem with collections or anything like that in our area, so there wasn't really a big bang for our buck to turn that on. But pretty much everything that was GA'd at the time of go live, we put into registration and scheduling. I'm not sure if any of you folks use orders of scheduling for your clinics, but we've put in, I think, 30,000 future follow-up orders since go live for follow-up appointments in PowerChart.
Yeah, CAMC uses orders of scheduling and scheduling orders both.
For you guys aren't in CPM yet, right?
No, we're not in CPM, but we do the orders of scheduling. It comes through a scheduling appointment book and the request queue, and then we pick it up from there.
Do you do that for, I'm curious, sorry if I'm going off topic, but do you do that for your ambulatory follow-up visits or just for diagnostic and surgical procedures?
That's for diagnostic. We're not even really there for surgical procedures yet, just really the diagnostic side. And we there's, another process that we do to minimize authorization denials on observation patients, and maybe at the end of the call I'll share that with you. It's a pretty cool process for our in-house patients too. We get them to hit a queue. But anyway.
Yeah, we actually do the follow-up orders to scheduling for all follow-up. So like your 60-day your 2-month follow-up with your primary doctor or your 2-month follow-up with your surgical. And CPM, it's very, I think we're the first GA client to do it, but it's very easy for the doctor to put the order in, and it gets scheduled at checkout or hit the queue otherwise.
Yeah, that's pretty
So,
cool.
while we're going through this, there is the ability to have each of you do demos of things to other sites. So on our PMO call, for example, CAMC is using a PPM tool for their project management office, and they did a demo of it. So if there's something that you think that you're doing that other sites could benefit from, then just volunteer to demo at a future meeting. What version of Millennium are you on at Concord?
2015.29. We just had our project kickoff yesterday for 2018. We are going with 2018.1.10. Anxious to see if you guys have could on this list put what version everybody's on. That'd be awesome too.
Yeah, that's what it's at the bottom.
Oh no, because there's a huge discrepancy with 2018.1.8.9.10. There's especially on the registration and scheduling side.
So
I might want to.
Can you tell me what version 2018 you're on?
I will look it up and let you know, because I'm not.
Thank you.
You're welcome. Give me a few minutes.
I might hit you up before we go live with it.
Yeah, that's exactly the point of this call, is to allow people to share between sites. So next, I don't think anyone from Covenant was able to join. Is that correct? Okay, so we'll skip over to Dawn from Lowell.
So, Dawn Arctur, the Director of Patient Access at Lowell General. We are just north of Boston in Massachusetts. We're a facility hospital, about 400 beds or so. We are not using CPM for anything. We are completely on Win32 for registration and scheduling. We do have some of the physician practices that are using other EMR systems or CPM systems. AthenaNet is the primary one in the community that we do have interfacing both registrations and appointments into Millennium so that Millennium can be used for the clinical documentation. We have a hybrid there. We have, for our bolt-ons, we have quite a few bolt-ons throughout the system. We're using many of the Cerner transaction services, so we have Televox for our appointment reminders. We're using address validation and verification, propensity to pay we have turned on as well. We're using CPDI for the scanning and images. We have teletracking is our capacity management application that we're using. We're not using Cerner's module there. We use Vine Tracker, which is all of our faxes and imaging, and we're working on a documents import from Trace into Millennium. So that's a project that's just getting kicked off now, so that's going to be another integration point there. We have Change Healthcare. For now, Lobby is used for our, our check-ins and tracking patient volumes. We had the QA system and the eligibility system, but we are switching to Experian. We have eligibility and estimates live. We just went live late spring, early summer with both of those, and we just kicked off a project to turn on the full QA suite in Experian and also authorizations. We'll be moving forward with that. And we do have Cerner Hub orders that integrate those, allows us to have more future orders come into Millennium for scheduling with ECW and some of the other EMRs that are out in the community.
So, hey, this is Tammy again, and I know this is probably way off agenda. Sorry, Patty. So I just want some feedback on the Experian eligibility and RQA. So you said that you're on Win32 fully?
Yes.
Yeah, so we are too. So I want to share some pain points that you might take into consideration that might prevent some of the issues we went through. On the full RQA, take a little bit of extra time on some of the alerts related to the subscriber name. So essentially what we found is when the alert was firing, telling the user that they had the wrong subscriber name, it's because we were pulling from the medical record level name in the interface versus the insured name. And so our interface folks had to swap that around in the message that went to Experian, and it caused like havoc. You can imagine, 200-300 users out there panicking at one time because they keep getting alerts that they can't resolve. And
funny
then,
you mentioned that, because we actually, with our eligibility, we turned on a couple of those the QA rules, and that is one of them, and that happens to be our highest alert that triggers.
So it was our highest too, but there is a fix for it. So in your interface, have your team go through and instead of pulling subscriber name, because I think that's the way it's built on the Cerner table, they have to look for the insured name on card, I believe is the name of the field. And what our interface team did is they just pulled the insured card name and threw it in the interface under subscriber name. So then when it went to Experian, it actually went correctly because Experian accepts it as subscriber, but we're just tricking it and pulling it from another field. So that was our biggest and largest one. So it wasn't necessarily that they were doing it wrong. It's that the system wasn't, it was getting the medical record level name, which doesn't always match the card name. You know what I mean?
Correct.
So there is a fix for that. And I just did a a presentation at the Experian conference and shared some of that too. And then while we're at it, on the authorization tool, so we're live with just about everything Experian, but on the authorization side, I caution you on the Experian knowledge base. At CAMC, we determined that it was better use of the tool if we build our own internal knowledge base, and the reason for that is the rules that were set based on, Blue Cross requires CPT 1, 2, 3, 4, 5 to have an auth. It didn't match our local payer rules. So there were so many discrepancies that you really couldn't rely on it. So we built 48 knowledge bases here on site using our own team. So just an FYI.
So how long, maybe we can connect on that. I'd love to know more about that. What was the work effort, and how do you plan to maintain that going forward, are some of the two questions that first come to mind when I hear that.
Okay. Yeah, sure, we can touch base, and I can share some of that with you. We've got pretty detailed tracking on that, so I'd be more than glad to share it. But just when I heard you just went live, I was like, I need to tell her. She's on 132, so you're going to have an interface issue there.
So Tammy, see if it'll let you in Teams. If you go to this eligibility channel here, see if you can see this channel, and if you can, there's a file section here. If you wanted to put your PowerPoint from your Experian presentation up there, if you don't mind sharing it. I'm guessing you don't.
Yeah, I don't mind sharing it.
Yeah, and so that, but by all means, you guys should connect afterwards. So you'll at least have everyone's email addresses from the invite for this meeting. But, we can also put everybody's email addresses and phone numbers, if you all want, into this document here so that you'd always be able to go back to it. Like right now, it just has the name. Dawn put in her email address. But do you guys want me to update this later to include email addresses and phone numbers, or are people more comfortable if we just leave it like this and you connect yourselves?
You can have my email address. I'm fine with that. I do have an issue here at CAMC accessing the site. So I think I told you about this. Our IT team supposedly pushed something out so I could get in. But this is the closest I've been able to use Microsoft Teams, and that's seeing your screen. So I'm hopeful I'll get there.
So if you want, you can. If you want to send that to Dawn directly, that's fine. But if you also think it'd be helpful for other people who haven't implemented Experian yet, if you want me to post it, you can send it to me and I'll post it for you.
Okay.
Okay. So Dawn, the other thing that's interesting is that you guys went live with what we used to do with a lot of Cerner implementations. You went live with scheduling way ahead of registration from here. You went live in 2007 with scheduling, and not 9 years later for registration.
Correct. Yes. So we had a lot of workflows built around that, and then when we switched to the Cerner registration, there were a lot of things that we needed to change and tweak so that they worked together more effectively. And I've run into a couple issues or, gotchas that we really weren't aware of until after we did the flip.
So that might be important to Cynthia, because they also went live with scheduling with the clinicals, and they're still on STAR registration, and they won't be going live for years. So she may reach out to you at some point as well. Do you know which 2018 version you're on?
I think we're on .22. But
so 2018.1.22, is that what it is?
Yes.
And just for the record, CAMC is on 2018.1.6.
Yeah, it can't be 22. That's getting under. I think 13 is the newest. I think.
Okay, we could probably confirm that.
Okay, so I'll put .1 question mark, and you'll get back to me. Sure. I'm not sure. Like, this document is going to be posted there as well. So I think I've given you all access that you can go in and update them, but you'll have to tell me afterwards whether or not you can. Okay, and then the alphabetically last client today is Northside. Cynthia, do you want to introduce yourself and Northside?
Sure. Cynthia Devroye, Manager of Financial Applications at Northside Hospital in Atlanta. As of the end of August, 5 facilities. We just merged from a 3-facility up to a 5-facility. We have 240 ambulatory sites, that is inclusive and mostly imaging sites. So I don't actually have the breakdown of clinics, but and we went live in 2018 with scheduling. We have not gone live with registration or CPM, but we are next week going live with CPM for one physician practice, and then I'm sure we'll be rolling out quickly after that.
Okay, so and that's for both. So you're doing all CPM. So I'm going to add that. I mean, if you're going live next week, I might as well add it, right?
Yep.
Okay.
And right now we have Smart ID, MCA. We do have appointment reminders too. I forgot about that. And we are upgrading at the end of this month to 2018.1.9, I think. Let me just flip over. Yeah.
Sorry, and when's your go live for the upgrade? In November, did you say?
It's at the end of October. I'd have to double check it.
So you're not.
Sure.
So you're not live on this now. You're going to be live in October.
Correct. Shortly. We're doing the CPM and then shortly thereafter doing the upgrade.
And are you doing registration in CPM?
Yes.
I'm going to send you a CR right now that you should be aware about.
Thank you.
Yep.
Okay, so I will save this and close out. And like I said, I think I've set it so that you can all go in and update this. If you try to update it and can't, and there's something that you want to share, you can certainly send it to me and I'll update it as well. The minutes and things will be out here, but they're right now in my own OneNote because I couldn't get it copied over. So thank you everybody for going through and doing the site introductions. And I guess I never introduced myself. I'm Patty Marshall, and I know most of you, and I'm from Make Solutions, and we're hosting this as well as some other roundtables, just hoping to get more client sharing where you don't necessarily have to go through Cerner. So the idea was just to make information more readily available. So the next topic for today then was supposed to be premium eligibility. And I know you guys have started talking about that already with Tammy talking about their recent implementation and her presentation at their user group meeting, and Dawn talking about the fact that they're just turning it on now. Tammy had added this topic to it. Was there anything else that you wanted to discuss about eligibility, Tammy?
No, I just really wanted to see how other sites using Win32 were using the functionality. In addition, CAMC's on out-of-process scripting to allow Experian to post back corrected ID number or group numbers, but we do not let out-of-process scripting post back any type of subscriber information since Cerner's built where you query the database for subscriber change. I just wanted to share that and see how others are doing it. We're not doing batch anywhere at this time. I also wanted to point out, I don't know if it's important, Patty, for the notes that you took a minute ago, but we also have Change Healthcare here at CAMC to do like some of our disability stuff, but it's nothing, directly related to Cerner.
Sorry, it's Change Healthcare for what?
We use them, it's our disability vendor, process disability applications.
Hopefully this opens very quickly. There we go.
And also, I didn't share this in the introduction, but I oversee acute registration, hospital registration, financial counseling, centralized scheduling, insurance verification, and pre-certification. And I have around 140 folks on my team.
Okay, so going back to the premium eligibility, what was that process that you talked about? Out of what? Out of?
It's Yeah, so it's called out-of-process scripting, and so the way that it works is Experian is given a login to access a hidden conversation inside of PM Office. And so what it does is it evaluates if there is a change needed on the ID number or group number, and it goes in almost like a person and it replaces it with the correct number. So it's just a backup for the user who, either misses the alert or doesn't fix it or, hits a manual resolve when it really wasn't corrected.
So it updates group number and what else?
The ID number.
Uh-huh. And so that's one way from Experian to Millennium, but there's nothing that goes from Millennium to Experian in this way. It's just the regular interface messages that go.
Yeah, it just goes by HL7, 270, 271.
And so what else did you say about the out of process scripting? There was something else you said.
Yeah, so we also use it for the authorization to be posted back inside of Millennium. What I was hoping would happen was similar to the way that Experian worked with Envision. We were a previous Envision client. I was hoping you could post it back real time, but it doesn't. So this Experian out-of-process scripting happens, of course, after the registration's been completed and the script runs.
Is that something that you're working on as well, Dawn, or is this something you would like more information from Tammy on?
So we do have some out-of-process scripting in place with Experian as well, not specifically for the ID and group number. So that's an interesting one that I potentially can follow up on. I understand how the whole process works. We're actually doing that, or we're in the process of trying to implement that on the estimate side, to have the estimated patient responsibility come back into Millennium and populate the estimated patient responsibility field. Just so that we have...
so I would love to know more information about how the estimate tool works for you. So we've not started implementation of that yet. That's still slated for sometime in 2020. Currently, we don't have an estimation product. When we converted in 2016, our estimator tool was an Envision product. So right now, we don't have any way really of giving the patient an estimate. So that's a limitation for us.
Yeah, we're still working through some of the kinks with it. It's interesting. Some of the hurdles we've come into is when there's more than one health plan involved. And, obviously those are hard to create estimates for anyway, but even with some of our alerts and things like that are causing some issues with us. Overall estimates are okay. We're like I said, we went live in June, so we're still tweaking something. We're running into issues when there's multiple tiers in the plan. So, having Experian identify which co-payment really applies. We are having issues with making sure that Cerner is communicating the correct service type and identifying the correct benefit. It's fine for eligibility when you just get general benefits back and you can see they're active, not active, the group number, those types of things. But when you try to do an estimate and you really need to know what the surgical benefits are versus the emergency room benefits versus the, an ambulatory surgical facility co-payment and deductible. So we're having some challenges with our more complex surgical visits and really identifying the correct benefit to apply to the estimate. So it's an ongoing process there. But in regards to the out-of-process scripting, so I'm be interested in the ID and group number. I wonder, we're also signed up to do the bad plan code. We just kind of went live with some of the bad plan code detection alerts and are continuing to work through some issues there as well. But we're scoped to do the bad plan code.
So those are alerts, not out-of-process scripting, right?
Well, that's an alert, but the next phase is bad plan code repair, where Experian can actually repair the plan code within Cerner if, we registered as Blue Cross HMO, but it really should have been Blue Cross PPO. So I wonder, I would assume it's, again, probably an out-of-process script, but Cerner, I guess there's an issue with it right now, and there's a release that's coming out in the spring that's supposed to help with that, and we'd be able to implement the bad plan code repair at that point.
Yeah, so we have the same issue. We turned on some of the bad plan code alerts, but you're right, until we're on a higher code of Cerner, we won't be able to take the repair. We're in the same issue.
Yeah. And I did confirm, I was totally way off when I said .22. We're on .06 for registration and patient accounting.
Okay, that's what we're on.
Yep, there's some type of package that's releasing this spring that we're going to look to take.
Sorry, you said .1, .6?
Yes.
Unfortunately, I didn't leave this open, so let me quickly do that. And I'll just leave it open in case anybody comes up with anything else. Okay, and so Dawn, you are going to get information with regards to the out-of-process scripting, estimate, patient responsibility to Tammy, and then Tammy, you are going to get information on the update group number and ID number back to Dawn, right?
Yep, sounds good. And Patty, I sent you the presentation.
Okay. I guess I should be better at typing. Okay, is there anything that anybody else wanted to add with regards to premium eligibility? Okay, so the next topic then was inpatient notification process. Is this IMM, Tammy?
No, so I just wanted to see how every, sites are different. So I'll just share the kind of high-level process that our team does here at CAMC on the notification. So patient access is responsible for the inpatient notification, and then our case management team is responsible for obtaining the inpatient auth. So we tried a few different processes after we went live with Cerner, and really it wasn't until we got to our third process that we really found a win. So I just wanted to share with you guys, maybe you guys have another way that you're doing it you can share with me. So essentially what happens is that we found that the work list inside of PM Office was really unusable for what we needed to do with it, the way that CAMC functions. We also tried using Discern alerting, so to alert our inpatient notification team to notify the insurance, but there was a lot of discrepancies there, especially when we had status changes. So our third and final process that we're using today, so a patient comes into the facility, they're admitted to the hospital, our inpatient notification team, they actually work out a revenue cycle out of a work queue or work list. And so encounters qualify for their work list based on work items. So that would be either the initial encounter of inpatient or observation and or a status change. And then our team will either call the payer, send them something electronically, the various ways that we do notification, and then they actually clear that patient off the work queue using an action item. So I was just curious to know how other facilities with Win 32 or are using your inpatient notification team, or do you have a team that does that? So I think I was just seeking clarification on somebody else's process.
Hi, this is Dawn. I can jump in. I can tell you we agreed that the work list in PM office doesn't work for us, so we have reverted. I like your idea of revenue cycle, and I'm trying to look for more opportunities to have the team leverage revenue cycle, and I think that's a good opportunity there that you referenced. But right now, we're very archaic. We have document routing set up so that if the encounter type is changed to inpatient, it will automatically print a face sheet to the authorization office, and they're basically running to the printer and pulling the face sheets off to work their authorizations from there. That entire department is somewhat attached to paper. So I've been in this role only for 9 months and trying to change their mindset a little bit and pull them away from paper and automate some of these processes. So that's where I mean about I like the idea of revenue cycle. But that's kind of where we are right now, very basic. But I guess that brings me, you talked about status changes, so maybe that's a topic for our next meeting. I'd love to hear more about how organizations are managing or handling all the status changes. Here at General, we have over 500 a month. And we're not that big of a facility, and I'm interested in exploring the Cerner's order-driven status updates. I know that there's been issues with that, but I don't know if there are any clients here that are using the Cerner orders-driven status updates, or Patty, if you have clients that
I think almost everybody on this call except Lowell is doing that. So CAMC is using patient status order, and Northside is using it, but is using it with notifications like the same as you're talking about doc routing, I think. Are you using patient status order in any other way, Cynthia?
I don't think so.
So you're using it just with paper, which is similar to what Dawn talked about.
Yep. Yep.
It's driven from the patient status order, as opposed to, it sounded like yours was based on somebody updating the patient type manually. Is that right, Dawn?
That's correct, yes. So other facilities that are using it, I guess, are really doing the order drives the patient type and really makes the change to the encounter and all of those components.
Right. I think everybody is using that functionality except for you, but I know because for Northside, it's kind of an offline process because they're not using registration, so it prints to the registration area, and they do updates then in the star side. What about Concord? You're using the PSO, right?
Yeah, we're using the PSO, and actually we're using the PM office work list. And for status changes, we have a report that we run. I know Cerner. We're on a collaboration call with Cerner. I know they're bringing in something for status changes into rev cycle, like a work list to capture those status changes.
So I think CAMC has done a lot of rev cycle work directly with Cerner, but I think this was something that Jason Deem cooked up for you, right, Tammy?
Yeah, for the notification, but I do want to point out on the PSO itself, so current state right now, our PSO does drive encounter status changes. One thing that it doesn't do is update the accommodation code, and we're going through our rebuild of an optimization of the PSO process, and we're currently in that phase of testing and making sure that's right and rolling that out. So in the future, the accommodation and everything associated with that PSO will update on the registration. Current state, it does update the encounter type to be inpatient or observation, but there's a few fields that would still need to be updated. For example, using the patient type accommodation code mismatch. That'll go away with the PSO changes that we're implementing.
Excellent. But yeah, I just kind of resurrected the topic here at Lowell. I've reached out, Patty, to Amy specifically, and she's done some conversations with the clinical leaders, and I think her hope, she'll be at CHC, and she's going to try to take some information away from CHC to bring it back to Lowell. So having some counterparts that I can help hook up and help drive that discussion would be extremely helpful for me. I think the clinical side is terrified of the concept, but from the access side, I think it's really, we have more visibility into all the comings and goings, so it's important that I can speak in articulate fashion on the subject and the benefits to it. So I'd love to maybe potentially connect up again later. Concord, did you present at CHC last year?
Yeah, just two of us did.
Yes, I went to that presentation, so thank you for that. That information was helpful.
And there is a, on the Cerner website too, there's I'm trying to find it, there's a collaboration call we did with a few facilities that all have the PSO in different versions of the PSO too. I know a lot of clients have listened to it.
Okay, excellent, thank you.
So it may be that, if we do PSO next time, that it takes the whole meeting. I'm trying to keep these to an hour long, but that seems like that might be an entire meeting. And maybe we get you all to send in sort of the questions and the topics around PSO that you would want to talk about, and then maybe we could try to have people speak to it more. So I don't know, but just throwing that out there. However you guys want to run this is fine with me. But it seems like PSO is a huge conversation all the time. So the one thing also that has hampered sites in general about PSO is if you don't have 24/7 case management, is who manages the process when case management's not around. So the next agenda item then was medical necessity process to include modifiers.
Oh my. Okay, so, oh gosh, I could talk medical necessity for 8 years. So essentially, I don't know how you guys are doing this from your facilities, but I'll just kind of give you a really quick overview of the problems that we have. So the medical necessity that runs when the patient is either scheduled or the physician puts in a CPOE or electronic order, that seems to work okay, aside from some hiccups we had during Go Live and some mapping issues. But it will alert the user that the patient needs a new diagnosis or an ABN. The problem that we have is on the walk-in side. So from the electronic version, if we get an ABN signed, it'll update and attach to that charge. On the walk-in side, the walk-in medical necessity check, it's not integrated, it doesn't store anything, it doesn't even attach to the charge. So therefore, it doesn't, when that order's put in the department, it'll refire and say the patient needs an ABN, they could have already signed it. So in addition, we can't get a price to print using the standalone medical necessity tool because our lab tests aren't billed as appointment types, which is ludicrous, but what it is. So our solution was to use Experian for the walk-in side so we could at least get a CMS acceptable ABN form. The problem that we have is on our walk-in patients, which is about 50% of our diagnostics, there's just no way to attach an ABN status to that charge. Just to give you further information, we have centralized registration. The registration occurs, and then the patient goes to the department where they will department order entry the test. So all those encounters are hitting an edit in our scrubber. We're sending them back to coding. Coding's looking for additional diagnosis, and or the patient account or the biller is going in the system trying to find the ABN. So how are you guys doing it?
This is Dawn. Pretty much exactly the same way, except for what we did do with the standalone tool. We decided not to use the Experian tool because we couldn't find a big win from the medical necessity perspective, especially for the walk-ins. But what we did do in the standalone tool is, even though our labs are not scheduled, we did build appointment types and associated the orders, our highest volume orders to the appointment type so we could effectively use the standalone tool. We have multiple appointment types. Some are just generic labs. Some of them we are able to group together based off of different panels and commonly ordered labs together. But at least we have the appointment set up in the standalone tool, so they select the appointment type of lab medical necessity only, and then they can select from the list of labs associated to the appointment type and generate the ABN that has the price on it. But other than that, I think our process is exactly the same as yours.
And that was what your recommendation was the key, right, Tammy?
Yeah, so my other question is when you do that, because it's a standalone tool, so are your registrars, are they entering the orders, or are those entered in the department?
They're entered by the department, so and we do not have medical necessity checking turned on at the point of ordering. So our lab doesn't receive the alert because we don't have that process turned on here at Little General.
And we have it turned off too, except in some of our RAD places, and we're trying to figure out why it's still on there. But so if your patient signs the ABN and registration, and then your department orders it, which is exactly what's happening here, how does your patient accounting department know that there's an ABN on file so the modifier can be attached?
They would look for the document. So we're using CPDI, so it's an e-signature document, so they would launch into images to see if there's a completed ABN.
Yeah, we're doing the exact same thing. We feel like after we, and I don't know your situation, but we feel like after we went live with Cerner, our medical necessity write-offs skyrocketed. So for a while, we were averaging and Patty, don't put this in the numbers, anywhere $300,000 to $500,000 a month in write-offs for medical necessity. So we've got it down significantly, but it's been a huge work effort. And again, it's so many hands are in the pot, and we can't send it out clean. We got to stop it and send it back through. So the other thing that we're doing for this process is when the patient presents to registration, they will call the provider, again, trying to get that additional diagnosis. If we get that, what we found is coding doesn't necessarily work from anything that I enter in registration, so we don't enter a diagnosis. We only have reason for visit. So if we were getting an extra diagnosis, coding wasn't able to code it. So we have a workaround of that. So we have created a form, and when we call provider's office to get that additional diagnosis, we document it on the form, we document who we talk to, and our compliance
on a
department.
power form?
No, it's a piece of, no, you manually write on it. And then so what happens is we scan it in, and it auto queues up for coding. So when that encounter gets a coding, it's already queued up for them, and they know that, yeah, this patient had an order that said hip pain, but they have an additional form here that, we talked to the office, and they told us the patient also has chest pain. That way it gets coded appropriately, and it doesn't hit the medical necessity edit.
It gets scanned in, and then it queues using WQM?
Yes, and I believe Access HIM. And then I just had one more question about medical necessity. I'm curious. So prior to the conversion, we used one FIN number for our surgical patients, and so we would pre the patient for their surgery, and then their PAT and surgery was done on one FIN, even if it was on different days. Current state, a patient gets a FIN for date of PAT, and then they get a FIN for their surgical appointment. So our physicians are ordering, standard testing for pre-admission testing, but I'm finding that they're hitting a lot more medical necessity edits than when we were doing them on one FIN and it had all the documentation from the surgery on it. So are you guys seeing that in your facilities?
That's a good question. We did a similar model. Previously it was one encounter. Now we've since moved to the two encounter model. I'm not really sure what the medical necessity rate is on those, but I think it's an interesting point that I'm going to follow up on.
Okay. It seemed to be a pretty significant amount of our overall medical necessity edits was coming from our pre-admission testing patients. I'm sorry, Patty. I feel like I've talked the whole call. Next time I will not talk.
Oh, that's okay. Oh, that's okay. So we only have 5 minutes left, and I do want to get down to the bottom, which is determining, do we want these to be monthly calls or what do we want them to be? So I only have 4 to-dos called out, and that was Tammy, and she's already done it, sending me the presentation. Dawn to send information with regards to the estimated patient responsibility to CAMC. Tammy to send information with regards to group number and ID number for for Lowell, and Dawn to follow up to see if they're getting more medical necessity edits with 2 fins for PAT and surgery. I know we had at several of the sites lots of discussions about 1 fin, 2 fin, and I know that was the absolute biggest headache at Go Live for CAMC was people choosing the wrong fins. And so I know when we were at Northside, we tried to do a lot to try to educate on that beforehand. Are you having problems with multiple fins at Northside, Cynthia?
We are having issues with multiple fins.
Yeah. Are you getting duplicate denials?
So I don't have. Let me clarify. Yeah, we're not doing this same medical necessity process, and we are not using a separate fin for PAT and surgery. So I'm curious about that change, but in general, we're having issues with multiple fins.
Yeah, so I think you went to use a single fin so that you wouldn't have the issues, and I guess it was, the ones who went live earlier were getting different recommendations from Cerner. So you're using single fin for PAT and surgery as long as it's within 72 hours or something, right?
Yeah, and we did before, so I don't think that was a change.
No, I know, but
Yeah.
The other sites were using a single one before too, but Cerner convinced them to go to 2 fins, I believe.
Yeah, that's correct. And so it's, again, we are one tax ID number, but we, on the multiple fins for different facilities per day, we have a issue with duplicate denials on the UB side. So it's a really big issue for us. So we're pushing everything to 1 fin. So we're in the process of doing that through our revenue cycle reboot process. But I don't believe that they'll ever take our surgical and PAT patients back to 1 fin.
So on this, Cynthia, was I right? Was it as long as it's within 72 hours, or was there no
I'm not sure. I don't recall
Okay.
that rule, but I can double check. I could be that I'm just unaware of it.
Okay.
Yeah, that'd be great. And then, so Cynthia, do they have issues when the patient presents for the actual PAT, if it's prior to the surgery? Do they have issues like getting the patient on the tracking board and things because it's all 1 fin and it really shouldn't be activated till the date of surgery? I would be interested to know, your process for that.
Yeah, I can follow up with more detail, but I've not heard of any issues with getting them on the tracking board.
Yeah, that'd be great. Thank you.
Mm-hmm.
One of the other reasons why it stemmed from issues with claims, but we're at a point where it does accelerate cash to be able to bill those PAT charges out, because patients can come up to 30 days before their surgery. So we look at it as opportunity to accelerate the cash, where we bill them out as soon as within a couple days of coming, and don't have to hold them up for weeks until the surgery is done, because there are payers who will reimburse separately. So that's what we're doing.
I can see that.
Okay, so quickly, do people feel like monthly is a good cadence for these meetings? And do we think that 11 to 12 is a good time? And so should I send out to each of you your availability a month from now for this kind of time slot? Does that seem like a good cadence monthly? Or did you all think it was a waste of time and you don't want another meeting?
No, I definitely appreciate the feedback. I just like to see, what other sites are doing so I can, see if there's anything we can improve on this side. I would do maybe every 6 weeks, Patty, instead of monthly for me. It's, there might not be enough time in between to investigate anything based on what we're doing here. But for me, I would prefer maybe every 6 weeks or so, or, every 2 months. But
do people think every 2 months or every 6 weeks?
Either is
I'm
fine with me.
Either's fine with me too.
Okay, so what I'll do is I'll put it every 2 months, and then if there's a special topic in the meantime, we can add a special meeting for a special topic.
okay.
Okay, thanks everybody for participating today, and I will send these minutes out as well as post them on the site, since I know that Tammy at least can't get into the site yet. And again, I'll send out an email to try to get availability for 2 months out from each of you so that we can get the calls going. Thank you, everybody.
Thank you.
Thank you.
Right, bye.